On December 10th, 2024, the WHI invited leaders from 3 different community care hubs located in Maine, Western New York, and the Kansas City region to share how they have begun to better integrate health and social services in their communities. Each organization gave a brief overview of their organization, followed by a panel discussion where local stakeholders could ask questions related to how we might do the same in Washtenaw County. For the full slide deck and information on the organizations who presented, please see the video description.
Well, thank you for inviting me. I hope I meet your expectations today, and look forward to answering any questions you have. Healthy Living for Me is a fledgling community care hub in Maine, and just like you all discussed a few moments ago, we are attempting to bridge that gap between community-based organizations and healthcare, and also find a sustainable model to make it work. I think the biggest takeaway from all of us is this concept around a community care hub is not something that Maine or I created. It is something that's being generated out of ACL, Administration on Community Living, the CDC, and CMS. Next slide. So this is our mission and our vision, and basically it mirrored or married up into what is a community care hub. What I'd like to do, if Matt, if you could click video, Healthy Living for Me video, it can kind of give you a little.
I'm gonna kind of reverse here, but
Our communities can't thrive if people don't have what they need. Community care hubs can help. A community care hub is a local or regional organization that makes it easier for everyone to access support needed to live healthy lives. That might be improved access to food, affordable housing, reliable transportation, social time, or access to medical and behavioral health care. Community care hubs were created from the lived experiences of patients and take the voice of the community seriously. They are trusted partners to healthcare providers, hospitals, and insurance companies since they know the community well. Hubs match people with community-based organizations that are already providing support so that patients and their caregivers can rest assured knowing that they're getting needed services. Community care hubs also handle health industry regulations, patient privacy and information security, contracting, and payments so that community-based organizations don't have to. Did you know that Maine has its own community care hub? It's called Healthy Living for Me. We're vetted and trusted to work with insurers and healthcare providers to connect people with resources. We support an existing network of community-based organizations to meet your community's needs and lessen their administrative load. We offer a variety of classes that promote health and prevent diseases. And social care coordination, sometimes referred to as complex case management, for folks who need extra help navigating the web of community services, especially caregivers. We're here with answers and encouragement for them too. To join our network or use our network to better serve your patients or to fund our innovative work, visit healthylivingforme.org. or call 1-800-620-6036.
All right, maybe go back to the slides. So I thought you'd rather listen to a video or watch a video, a little cartoon, than listen to me very boringly explain what a community care hub is. I think that would have taken me 30 minutes to explain. I guess the next thing is how did we divide up our community care hub? How do we operate? And right now we're kind of caught into a 3 things that we do or we attempt to do well. One is health promotion and disease prevention. A lot of that, I think I heard that there were AAAs in the room, or organizations that have worked with the AAAs, and you know that evidence-based programming was almost the beginnings of a community care hub, or when they called it the Community Integrated Health Network. And so we have a network of CBOs that work with healthcare, of which even healthcare is part of the network, where we offer a variety of evidence-based classes. Chronic disease, diabetes, intellectual and developmental disabilities, caregiving, and falls prevention. And we actually chair the Maine Falls Prevention Coalition. The second thing we do is social care coordination. And I think in the video they said sometimes referred to as complex case management or care management. That comes in a variety of flavors. We basically are capable of doing something as simple as a health risk assessment or an assessment on behalf of an insurance company, all the way up to following somebody for 30, 60, or 90 days. That little quote off to the side from a federally qualified health center CEO, we have a contract with them to follow people for 30 to 45 days. Who are struggling, who are high utilizers, and are struggling in figuring out how to better use the health system and address their social determinants. And then we do something that we kind of fell into. We're pretty good at being a convener of the community, and one of our projects, which might be of interest to this group that we're today, is what's called a Rural Community Health Improvement Partnership, RCHIP, and we helped create we were awarded a grant about a year and a half ago, 2 years ago, to address rural health and the gap between healthcare and CBOs in Somerset and Kennebec County. So those are 2 counties out of the 16 here in Maine. Next slide. So just a kind of little bit about what is in the SCIP and what's in this little partnership: 11 community-based organizations, 3 health systems, 1 healthcare advocacy organization at Maine Primary Care. The Maine CDC is involved as well. Major sectors represented are public health, healthcare, housing and economy, behavioral health, and social and familial services. Next slide. Let's see what we got here. Oh, we're an awards recipient of the U.S. Aging Grant to further develop the Community Care Hub. It's a 2-year grant, and it was a nice grant. It's $468,000, and I would say it's never enough. And I know that sounds selfish, but we're trying to build the hub, how to make the hub stronger. And the areas, there's 6 pillars that we concentrate on, but I'll just report. I think I threw 4 on here to keep the slides small. Strategic business development, which includes governance. How should we be governed? Are we part of another organization, or is it an independent organization? Should it be spun off? How do you take community voice into account? Network recruitment. How do you onboard and keep and retain CBOs? And how do you keep payers, insurance companies, health systems, ACOs? If we do not have managed Medicaid in Maine, but your managed Medicaid, how do you keep them happy? Contract administration and compliance. Healthcare, I'm probably preaching to the choir, is highly regulated. It's a lot of compliance, and CBOs are not used to that. And so how do you bring CBOs up to a level where they've got healthcare's attention? And a big part of that is information technology and security. Healthcare wants to make sure you can protect their data, protect their patients' data. And if you can't, they don't want to play with you. And these are big players. One contract that we have, and unfortunately we're losing, and maybe we're going to lose the contract, was with Aetna. Aetna has gone through some financial difficulties lately and have cut all national contracts, but they're owned by CVS, and CVS is, I think, a Fortune 5 company, and so you can imagine what they bring to the table and what their expectations are. And when you're dealing with a payer like that, it can become complicated very quickly. You also see how you could also get firsthand or front row seats on how come they cost so much, but that's a whole nother story. Next slide, if there is any more. That's it. That's all. That's a very high level. I think it's better. I've always found in this environment, answering your questions. But hopefully I've given you enough information to stir the brain a little bit. And when we get to questions, I'll be very happy to answer.
But thank you so much. So next we're going to hear from Tane and Christy from the Mid-America Regional Council.
Hello, everybody. My name's Tane Lewis, and I'm going to start us out giving just a little background on our community care hub, and then I'm going to pass it to Christy to give you a little bit about our transition to the future. So next slide, please. So our community care hub is sort of pancaked inside of the Mid-America Regional Council, which is a larger organization, and it's a federally designated metropolitan planning organization. It's also the designated AAA for our region, and serves as a forum for collaboration in the region. So just kind of an infrastructure piece of how we are developed. We're not an individual AAA on its own outside. We're housed within this regional council. Next slide. So this is just what we came up with as that entity is our Mid-America Community Support Network. We like to just shorten that to Community Support Network though. So from here on out, you'll hear us referencing the Community Support Network or the CSN. Next slide. We don't have a fancy video. Love that video. That was a really great introduction. So hopefully this will just be more of an overview of kind of how we brought this to be. So our community support network covers 2 states because we're a metropolitan region. And so this map just shows you the counties that we cover on each side of our state line. Next slide. So it all began for us in 2016. We began doing some just background, gathering information, researching the whole idea. It was kind of a fledgling idea at the beginnings in the national learning communities. And so we started gathering all the information that we would need to start thinking about what would serve best for our community. And we did some return on investment studies, healthcare statistics studies, reviewed a lot of CMS guidance, started really digging into social drivers of health, determining how it would be that we could best serve our community in that way. We then started gathering stakeholders, kind of it sounds like what you're doing now. In 2017, convened the stakeholder group, identified which health-related social needs that they would be interested in serving, who it is that we thought would be able to provide those services, kind of identifying even what that community integrated health network approach would look like. And then essentially by the end of those stakeholder meetings, we came to the conclusion that our agency had the best existing infrastructure to launch a community care hub. We're not wedded to being the only organization that does, the core infrastructure functions, but we did have the existing, pieces in the beginning. We also engaged with a lot of consultants. So we brought in community integrated health network leaders across the nation to give us advice. We participated in in learning collaboratives. We brought in some of the aging and disability networks consultants that came and met with us. Now part of them are with the Center of Excellence. So that's been a great journey. Just kind of gathering as much information as we could. And then next slide. And then that stakeholder group kind of morphed into a steering committee. Got a little bit more into that nitty gritty, brought in CBO administrators across the region that could provide services that were needed, and started developing a standard service array that we could package and pitch so that we could start trying to approach healthcare entities with our service package and see if we could get anybody to bite. And that steering committee also provided just sort of a regular feedback loop to us so that we could keep bouncing ideas and grow and morph as needed. We then began developing really the standard network partner agreement. We got into those standard documents that you needed to have in place in order to execute any contracts. So we were during these planning period, before we were launching any services, developing everything that we thought would be necessary. And we went kind of, I would say, to the highest level of requirements. So we were looking at Medicare contracts, essentially to make sure that we could meet that level of adherence and compliance and be able to execute a contract as needed. Even if it wasn't at that highest level, we'd be ready for the most required standards. We also created a standard data sharing agreement. We knew that would be needed to have in place. We worked with our lawyers to get all that ready. And then we started working on our initial funding, which came from philanthropic grants to begin with, to give us a little bit of startup money to make sure that we had the funds needed to dedicate staff time and consultants to doing this infrastructure work, and then identifying some of our braided funding options that might be available. We also leveraged, we had in 2018, we had an ACL grant for evidence-based programs. And we leveraged some of that grant dollar, which also required a statewide network, and that infrastructure that was included in that with the standard network partner agreement, a standard subcontractor agreement, a standard business associate agreement. All of that, we were able to join forces for that so that we could be ready for that grant, as well as be ready for any healthcare entity that came into play. Next slide, please. You may have to click. There we go. So, like I said, on that MA4 network is what we called that group that did the statewide work with the ACL grant for our evidence-based programs. We utilized that as our kind of understanding of how to get everything going. It was already kind of built into the system. We were able to be building upon it to make sure that we could do everything that we needed to do. We also referenced a program that we had been involved in for a short period of time before that, which is the Veteran Directed Care Program. And if any of you are participating in one of those, the VAs across the country, I believe by the end of this year, are supposed to have, every VA is supposed to be offering that program. So that program helped us to think about like the cost, the pricing that we could put on services, the workflows that may be needed, and some of the policies. So we were bringing together kind of all the things we were currently working on to come across with a standardized package so that we would be prepared. We also, like I said, participated in some national learning collaboratives to make sure that we really knew what the trends were and where people were looking. You can go to the next slide. And this is just a graphic, kind of a lot like the last one, that just kind of shows you what kind of graphically what that looks like to be a community care hub, where you have the hub sort of in the middle, just serving as that infrastructure, providing that coordination, financial administration, some CQI, quality assurance, and IT support so that the skeleton is there. And then the primary circle of providers is the CBO partners on the outside of that. And then we are able to exchange information with healthcare entities, provide data reporting, all of that back, and make sure that all the patients that are referred, or the participants if they're referred through a different kind of entity, not just a healthcare entity. But this prepares us to be ready for that, and we are able to do all of these components. This initial group of on the green boxes were our initial array of services that we offered. So, your typical community care management, transportation, evidence-based programs, meals and nutrition assistance was our core group of services that we started with. You can go to the next slide. And then as we were preparing, thinking everything was going to go wonderfully, we were ready to launch in 2021 actually was our plan to launch with our first healthcare entity, and then COVID hit. And so we had to jump fast. We had to get everything ready and rolling a lot faster than we had initially anticipated. We amazingly had made a contract come to fruition much quicker than it usually does, because they really needed our assistance. So this was with a commercial plan. We did a COVID pilot where we were supporting their members who needed some assistance with essentially with being able to stay in place when they needed to. So providing food and other hygiene supplies, care package kind of services that they might need in order to stay at home for 2 weeks during that period of time, if you recall that. And we had to launch that fast, and it went for a year, and we got 10,000 referrals. So we had to be super ready to go, and amazingly, we were very successful, and it came together great. I was scared to death it wouldn't, but it did. Our service providers were fantastic, and it was definitely being in the hot seat and learning as the plane was in the air and building that plane. So you can go to the next slide. Also wanted to just make sure that we all, think about the collaborations that we have when we're building these community care hubs, because it's so important to make sure that you're collaborating with others in your region, but also understanding like the partners at the federal level that can help you. So this is just a list of some of the key partners that we've had during our collaborations to develop the service array and the different services that our community support network can provide. And I think I'm going to ask Christy to kind of homonym a little bit about the community partners, collaborators rather, in our region, because she has a close relationship with them, but do want them on this slide. So you can move to the next. And then lastly, just wanted to kind of give you my 3 pillars that I always think about when thinking about how to make sure that this community care hub model can work. And like I said, collaboration is key. Having contracts is very key. Having those standardized products that you can have ready to go, and then all you're having to do is spend minimal legal efforts, hopefully, to tweak contracts from partners that you may need that tweaking from. The other thing is to really think through your quality standards so that you can provide a package of services that have fidelity, uniform policies, streamlined workflows, standard operating procedures ready to go, and the oversight mechanisms that you might need to make sure that you can report back on those so that you can be held accountable for those quality initiatives. And then also to allow for accurate reporting of impact and outcomes to all of your partners, whether that be federal, state, or third-party funders. Having that infrastructure in place is absolutely essential, because if you're building out afterwards and trying to develop some of that on the back end, you could have some data contamination. Okay, so next slide. This is just my thinking on the lessons that I learned as I worked on this project with my team, and then I'm going to hand it over to Christy, who came in a little bit later in the game. So that's why we have a new director. Christy's our newest director, and so I didn't want to burden her with talking about the past before she got here. So again, standard contracts absolutely critical to quality assurance. Formal contracts are intimidating, though, so you have to be ready to provide technical assistance to any community-based organization that you may work with because they may not have experience with this. I found pretty quickly that a lot of our normal partners that we had been working with through our AAA had a lot of handshake agreements, maybe some MOUs. They did not have experience with these technical contracts that have a lot of requirements and the business associate agreement, all of that. So we had to be ready to provide a lot of technical assistance and guidance. My key, I think takeaway from it is start slow and build over time, which we weren't really able to do. We started slow, got the research done, and then had to jump when the COVID pilot happened, when COVID hit. So being, prepared for an emergency is one thing, but if you can pace it in a better way so that your learning curve isn't impacted so much, and you're not scrambling after the fact to try to put some of the infrastructure in place, would be a guiding principle, I think. I put on the screen, it's hard work, but impactful, very rewarding. And Christy, take it away.
Thanks, Tane. Good afternoon, everyone. I think we are actually about at our time, so I will buzz through these really quickly. Unlike Gerard, I would love to make sure that you have as much Q&A time as possible. Yes, I came to the team about 1.5 years ago, and in part because of this community care hub model, I come from the healthcare side of things, the clinical side, and so recognizing as we were working with hospital health systems and CMS on value-based payment and transitions to that model, it can't be done without the community. And so, we've got to figure out how to bring that piece along. Like Gerard, we are we are one of the COE grantees, and we're recently notified that we are one of the care transitions evaluation grantees. So learning more about what that will bring, but certainly showing impact is key to all of this. Next slide, I may skip through a couple here. This just gives you an overview of our work plan and objectives for the grant. I will say there are 3 groups that are really critical here. CSN advisory, regreening that advisory group, and that's essentially the purchasers, those that would be establishing contracts with the community care hub. We need to understand what they're looking for and what they need to see in order to implement those contracts. The CBO coalition, I'll talk more about that. And then, of course, a continuous quality improvement work group that is based on foundations of good models for improvement. Next slide. So this is a little busy, and I will admit I already found an error because I, in 2 places, noted it's so important to meet people where they are, but perhaps that just emphasizes how key that is. The biggest takeaway I want you to take from this slide is that foundation at the bottom. If there is not a foundation of community-based organizations to provide these services, there's no point in contracting. And so we recognize the need to shore up our community-based organizations, not just from a contracting standpoint and a services standpoint, but again and again, we would be in positions where we would hear healthcare entities interacting with community-based organizations, and the power dynamic is so different. So we need to find a way for CBOs to have a unified voice in this model and to make sure that they are strong and healthy. Next slide, please. I'll skip over this. Of course, these are the social determinants of health screenings that you are probably familiar with, and we position these because we need to make sure that the network can address as many of these, if not all of these, that hospitals and healthcare entities are identifying. Next slide. So this was the dilemma I mentioned earlier. These 2 are inextricably connected, and so far that's a hard thing to comprehend. It's a bit of a chicken or egg thing. I hear from healthcare entities that they're hesitant to contract because there is a capacity issue in the community. I hear from CBOs that contracts come and they go, and so we have to staff up and we have to lay off, and it's very difficult to predict. But until we get these 2 in sync, the community care hub will be challenged. Next slide. I will skip past this. It just emphasizes the need for community voice, and leave it there. Thank you very much.
probably helpful if you guys could hear us. So lastly, we're going to turn it over to Nikki with the Western New York Integrated Care Collaborative.
Hi, everyone. It's great to be here. Thanks for having me. Western New York Integrated Care Collaborative was formed about 7 years ago. And next slide, please. So first here, I just gave you a little visual model of our community care hub. So we're really, as kind of Jerry mentioned, we're that bridge in between healthcare partners who are very diverse, very different sizes and structures and communication pathways, data sharing pathways, and the CBOs who are all different, again, sizes, service deliveries that they do, populations they serve, business acumen. And so we really provide that, that integration of care so that the patients or the community members are getting the best of both worlds. We currently have 120 network members. When we started 7 years ago, we had 9. Our network is made up of county-based AAAs or area agencies on aging, independent living centers, health departments, and then a whole bunch of nonprofit community-based organizations. You can see our map where we're located. Buffalo is our biggest city. I don't know if I should say go Bills, but I'm going to. Next slide, please. Our mission is to really provide better health through integrated care. And, you know, by integrating that, the social care happening on the ground and in the home with community-based organizations with the clinical and medical care happening in your office is really when the magic happens and folks can really start getting their health-related social needs met so that they can follow the doctor's orders and meet their clinical health needs. And our vision is to represent community-based organizations across our region and help them get connected to sustainable integrated business models addressing the social determinants of health. Okay, next slide. So here's a little bit of our evolution. Back in 2014, which is actually 10 years ago, 2 of our county-based AAAs and 7 of their partner agencies started participating. They applied to participate in a U.S. Administration for Community Living Business Acumen Learning Collaborative because they had been hearing that, you know, health plans were going to start addressing social determinants of health. This is what they are the experts of. And how are they going to position our region to be prepared for that when health plans were ready for this contracting? So through that year-long business acumen, they did research on our region, what was going to be the best solution. And they decided that a standalone nonprofit agency to be the hub of a network of community-based organizations was what was going to work best for our region. So we started off with those 9 voting members. And from there, you know, in 27, that happened, they were incorporated in 2016 and 2017, we got a grant from a regional health foundation, and that allowed them to hire. I was the first hire, and my job was to create this network, learn everything I could, attend every learning collaborative that was ever offered, apply to become a Medicare provider. And we had a couple programs that we had become the administrative lead for, which was diabetes prevention program and diabetes self-management. So we had 2 accredited programs that we knew were billable through Medicare. So those were going to be the first 2 programs that we start with. And we did execute a contract for those both. Then we started and obtained more contracts as we proved the model. We gained more network members. I believe in 2019, we hired a second staff member. In 2020, we were able to hire a third staff member. By 2021, we had 52 network members. 75% of them were contracted to provide services. We don't require that they have a contract to join the network. They can just join the network for free and receive benefits of, network collaboration or free trainings for things like that. We also obtained more contracts in that time frame. Last year, we were awarded a Business Innovation Award. We were featured in the White House Playbook to address social determinants of health. And then in August of this year, we were awarded one of 9 social care networks for New York State's 1115 waiver, which is a game changer. It's an unprecedented waiver that is setting up these social care networks to form a network of community-based organizations to deliver services such as housing, food, nutrition services, and transportation to the Medicaid members in our region. And so 2025, we are racing to our launch date of Jan 1. And we now have 120 network members and we're growing every day. Next slide, please. So our role in the network is really that administrative hub. We try to take as much off the plates of the community-based organization who is doing the services so that they can focus on the people they're providing the services to. And we take on the administrative pieces of that. So advocacy for our community-based organizations, every forum we sit on, which we sit on a lot, we are speaking on behalf of the community-based organizations. We are constantly engaging the network, collaborating with them. We do all the billing and invoicing for these social care programs so that all the health plans we contract don't have to receive claims from 120 different community-based organizations. They're receiving it from us. And then we pay down our delivery partners. We're in the offices with the health plans and the payers, contracting with them, negotiating with them, and really forming partnerships with them. Again, Jerry mentioned a lot of these, the compliance we're doing in TAIN, any credentialing or licensing, we take that role on, reporting, data analysis, outreach and referral processing. We have a centralized IT system that all of our delivery partners use and document their services. And we have an entire training academy. So we're constantly training them, getting them ready for services so that when a health payer contracts with us, they know that whether the service was delivered in Erie County or Cattaraugus County, it's going to be the same service. Next slide, please. So here's a little bit of our governance structure. Our voting members are the top of our governance. They vote in our board members. We also recently added a second group of network members that are called allied partners. The only difference is they don't have voting privileges to vote in the board in the annual report. And they also don't sit on, I think like 2 or 3 of the committees. Other than that, they are full members. So the committees, we have CBOs embedded in every aspect of our organization. So they sit on our board, they sit on all of our committees. When a new network member is onboarded, they tell us which committee, we ask them to choose at least one committee that they're going to participate on. And so that we're constantly getting their feedback and it's informing the work we do. For the programs that we deliver, we have work groups, and that's where the staff that's delivering the programs at the CBO level has connection with us, and we're making sure from a quality assurance standpoint that they're getting the latest updates, any ongoing trainings, sharing best practices, resolving barriers. With our 1115, we're setting up a whole new slew of committees and a community advisory council and work groups. So this is all ongoing work that we're under development right now. Okay, next slide, please. So our funding, where did it come from? We started 100% grant funded with, I mentioned, the foundation, a regional health foundation of Western and Central New York, followed up by a grant from our New York State Office for the Aging, and then Administration for Community Living for the development of these community care hubs. But we always have a mindset of where else could we leverage the expertise. And now we have 120 different community-based organizations. Where could we leverage this and provide and partner for more services? So we have started doing consulting for other community care hubs that are interested in building their own, whether it's on our compliance program or on our governance structure or what have you. We are also master trainers on several evidence-based programs. So we offer trainings and receive funds for those trainings. We have contracts, and I'm going to show you the list of our contracts in a minute, with commercial health plans, Medicare Advantage health plans, and Medicaid health plans. And then we also have billable programs that we can bill directly to Medicare and Medicaid. So we became a Medicare and Medicaid provider, and those are the three programs: diabetes prevention, diabetes self-management, and medical nutrition therapy. Okay, next slide, please. Here's the list of our health plan contracts and the funding mechanism that allowed us to negotiate with the health plan. We have a post-discharge meal delivery program that's through a Medicare Advantage. That's what the MA stands for, and that's a supplemental benefit. We have several other coaching programs where the coach, which is staffed at the community-based organization, meets with the member and provides long-term care management. So that's community health coaching, similar model with falls prevention and caregiver support. Healthy Ideas is an evidence-based community mental wellness program. I mentioned our diabetes programs. Those are Part B benefits. With our medical nutrition therapy, it is a Medicare Part B benefit, but only for diabetes and chronic kidney disease. So we talked to the health plan and said, you know, all of your Medicare Advantage plan members who want to speak to a dietitian, we could do that under a supplemental benefit. So they added that. So now we can see any of their Medicare Advantage plan members who want to talk to a dietitian, and we receive over 30 referrals a month just to for folks who want to talk to a dietitian. A lot of them, and we attach the referrals right to our post-discharge meal program. So with that program, anybody that's been in the hospital for at least one night stay can receive 2 meals a day for 14 days delivered to their home. And they're asked, would you like to talk to a dietitian as well? And then we hook them up with one of our dietitians. Now, through this new Medicaid 1115 waiver, we are also contracted to provide housing supports and navigation to housing supports in terms of rent payments and home modifications, nutrition counseling and food delivery, transportation to health-related social needs services, and then navigation and enhanced care management. Next slide, please. The benefits of being in a network, if you're a community-based organization, is you have the hub agency to advocate on your behalf, to make sure there's funding designated to you, that you're incorporated. I would say a big win on that aspect is the Centers for Medicare and Medicaid have new billing codes that say and encourage providers, healthcare providers, to partner with CBOs to deliver these new billing codes. And that's because of the advocacy from a lot of folks on behalf of CBOs. You have agency doing strategy development to support the network, a centralized IT system. You don't have to go out and buy your own, referrals to your programs and to the programs you're contracted with us, making sure you're all set on compliance and quality assurance. You have regional coordination and network engagement. And for our network, it's free to join. Any CBO that wants to join us can join. Next slide, please. Additionally, there's free trainings. They earn revenue and sustainability. We do all the billing and claims for them. They have the ability to enter contracts that maybe they wouldn't have been eligible for because maybe they only deliver a set service or they're only in a certain zip code. But the health plans, they have to cover all their beneficiaries. So now, because the hub is contracting and has multiple CBOs to cover the entire beneficiary population, the small CBO can now enter into that contract. And then we also are exploring shared services models where when multiple of our CBOs are saying, hey, we don't have enough, we need a HR person or we need a marketing person, we're doing discovery to see, well, does it make sense for the hub to hire that person and then sparse it out to our CBOs? And then we're always here as their partner to provide technical assistance on any of their questions when they're delivering the services. Okay, next slide. I think I just have a couple more. This is just to show you how much we've paid out to our CBOs in from 2020 to 2023. So in 2020, we were just signing our first contract and just growing it from there. So we have paid out over $500,000 to 33 CBOs in the last 4 years. Next slide, please. I'm not going to go into the weeds on this one. This is just to show you that we constantly track our outcomes. The graph on the right shows you how many folks we've provided services as a network through these programs. But by tracking our outcomes, we can show the health plans that we're partnered with and other ones that we're trying to get more contracts with, how we help their members and improve their lives. Okay, next slide, please. And so upcoming, we're really racing to this launch of January 1 for our waiver. So that'll be, I was listening intently to Jane say that she got 10,000 referrals for the food program. We are required to screen all 400,000 members of Medicaid members in our region every year. So yeah, it's going to be a wild and crazy ride here coming up, but we are preparing for it and we're going to just one day at a time, right? We're also now integrated with our regional health information exchange, which will be really key for sharing data with providers and with the state. And then we're looking into pilots with some of our local clinical providers to provide those new billing codes I was mentioning, community health interventions, principal illness navigation, and care transitions. I believe that's my last slide. Thank you. Okay.
Awesome. Yep, we are unmuted. Everybody can hear us on Zoom, okay? Why don't we go ahead and give a round of applause for our panelists. Invite all of our panelists here. I will stop sharing so we can see you on the large screen here. To turn on your cameras. And while folks think of their questions, wanted to just kind of kick it off and ask you all how you went about navigating some of the challenges of meeting service demand, especially on the social needs side. I think many of the folks here in the room know that oftentimes even when we are doing screenings, people are asking for help for specific services. We're still having trouble meeting that that need just due to service capacity alone, and how you all navigated kind of addressing that in the launch of your care hubs.
Nikki and Jared, you probably have some response to this. Being the AAA, it's helpful because we've got community-based organizations that have that funding mechanism that is a bit more stable in terms of keeping capacity in place. Though it is a challenge. You saw that last slide I shared with you. And so I told Tane today, my dream is to get to 5-year contracts that are capitated so that we're not seeing this fluctuation or payment by referral that just doesn't allow for sustainability in the community. But Nikki and Gerard, I'm interested in what you think.
Yeah, it's been a challenge. We can only, up until this year, until this waiver, accept folks who have the health plan that has the contract with us. Because that's who we can then pay our CBOs for. We have a referral process that if they don't, then we can like refer them as anybody else. But for the ones that we get reimbursed for, you know, we have to first check eligibility. Do they have the certain health plan that we have the program for? With the waiver, this is really a game changer because the New York State is giving us upfront capacity funds that we then pay our CBOs ahead to booster their staffing and get them ready for taking on more capacity and reimburse them for delivery of services. So our CBOs are super excited. We're in the middle of all that contracting and sending out funds right now because we're supposed to launch Jan 1. So it's an exciting time, but yeah, so we'll have upfront funds to Christy's point, and we can reimburse. So, and it's every Medicaid member. So as far as every Medicaid member at least can be screened and receive this level 1 navigation, which is connecting to services, but then there's eligibility criteria for the level 2 services, which is really folks with chronic conditions that are in the highest needs. They get set up with the housing and the food and the transportation. Jerry, anything to add?
I could go on for a while, but it is so I started out my conversation or my presentation saying a fledgling community care hub, because the future sustainability is still suspect in that that we don't have, and it's huge, that 1115 waiver in New York. I've talked to Nikki quite a bit, and I presented the 1115 to Maine. It's expensive, but it's a game changer. And we don't have managed Medicaid here in Maine, so that's a little bit of a difficulty. So we're at the mercy of plans, and the plans are never promising to be there next year, and they all want something a little bit different, and so you do struggle a little bit of developing a menu of services. We've done that, and we've priced it out. That's probably something that in the last year we feel comfortable about. We now know what our costs are to do anything. What is now, can you get revenue to cover those costs? So you can say you can do X, but will they pay you Y? And does Y at least equal X? And that's and sometimes it doesn't. And you really got to watch, because you could very much fall into a trap of always being a loss leader, to use a MBA term, or and you can't keep loss leading. And so, and maybe I'm getting a little bit of ahead, but healthcare, especially payers, want something, and they don't want to fund you to build that infrastructure. But they want it. They want you to have some form of SHARP, or a social health access referral platform, that has API capability, that can transmit data to them, inform them of their outcomes, and that they don't have to do a thing. So I don't want to get too negative, but that's kind of that's the world but we believe that the community, something community care hub is needed. So you almost have to have that belief that it's needed in order to have the patience to stick with it. I don't know if it's going to look quite like what we look like today. You have to have a good environment. I would say New York is developing a very good environment to work in the community care hub model. There are other models out there. Oregon has interesting model, except it's very government driven, and government controlled. So that, healthcare CBO integration is needed. The patients demand it. So.
All right. Any questions? Or we got one back here. Go ahead and get started. And for the folks on Zoom too, feel free to raise your hand if you have questions. We can have you unmute and ask. So you guys participate as well.
Thank you. My name is Reginald Day. I am with Priority Health, which is a health plan in Michigan. So great segue. I appreciate that. I am curious, how should a health plan show up? I hear you talking, and I hear a lot that it relates to funding. But I'm curious, what are other ways that health plans can show up? Because that's one of the things that we're looking to find out as well. I mean, we believe in the model, at least I can speak to Priority Health, but we want to know, like, what is the significant way to do that? Unfortunately, or fortunately, I don't know which way to go with that yet, but in Michigan, we are not doing the 1115 waiver right now. We are using in lieu of services, which is something that the state has just kind of rolled out as we look at a way to integrate nutrition services for many of the Medicaid members in the state. So it's kind of somewhat of a two-part question there, knowing that right now we're using ILOS to begin the implementation of some of the work into hubs that are being created around the state of Michigan. In addition to that, as a health plan, what are other ways that we can show up? And that's for anyone.
I was not able to hear your question too well. I'm not sure if anyone else was.
Nikki, can you hear me if I repeat it?
Yes.
Okay,
yeah,
the question
please.
was, and correct me if you want me to add, is, so this is a representative from Priority Health, and he's interested in knowing how can a health plan show up in this space? How can they be supportive in these efforts?
Awesome question. I'll take this first and you guys please feel free. But with our first health plan that we contracted with, they provided us with upfront funds for our first contracts that we could pass down to the CBOs to help them build their capacity. And then we scheduled a standard operating meeting with them every week for 4 years, that we were developing more programs every year. And they were really a great partner and allowed us to grow and build. And they're really seeing their members are receiving meals, their members are receiving falls prevention programs and others. So they've been a great example of a great health plan partner.
Yeah, this is a question that's fun to answer because we can imagine what it should be. And I love it if a plan asks us, how do we show up? So fantastic question. Lots of things. Be in it for the long haul. think about the big picture, not the flavor of the day. I know within plans that's difficult to do because priorities shift every year. But if we think about the infrastructure that's needed for social support services, that 80% of what impacts health outcomes, it's going to shrivel up and die on the vine if we don't invest in it in a meaningful way and not a transactional way. So that upfront but committing for the long haul. As I worked with CMS, a lot of the feedback on those early innovation model tests was 3 years isn't enough to really see true outcomes. And so think about what the timeline looks like to truly test this model in your communities and with your members. And then the last thing I would say is think about how you partner in establishing measures of success. So experience to date is we, the healthcare entity, will tell you what we need to see as measures of success, not mindful of the fact that it's your data. It's not data we have access to. So together we need to establish those measures of success. And then we also need to think about where the data comes from. Is the data available? And then how do we together track that improvement? Last thing I'll say on the data piece is making sure that you have people at the table who are thinking about what truly shows improvement in data. So for example, if we're thinking about the aging population, improvement can't be, were they less expensive this year than they were last year? But we have to look at the trend of what their cost would be without this support. And did we at least stabilize or did we bend the cost curve? So that's really key too, as you're talking about measures of success and expectations.
I really not much to add. Be upfront with what you're trying to achieve as a plan. Understand, so the clearer you can be to a network or community care hub, the better they can serve you. So I'm going to take it from, there's all the infrastructure stuff that everyone talked about. So from an operations perspective, you're in a contract, you want something to happen. Be very clear about what, and understand or be aware of what risks you might be taking as well. And that I don't know, it depends on how mature the hub is. If the hub is just starting out, then you're investing. If the hub is more like Nikki's, it's just operational, you're more like looking for how does the hub solve your pain points? What are you? And so and hence is a problem because every plan has a different value proposition or different value that they're trying to solve. So honesty. I know that sounds corny, but honesty about what you're hoping to have happen, because there is times when I want to say to and don't look to pass your problem onto the hub in that, like, oh, you should be able to do this for $25 an hour of unit or something like that. And yeah, well, we're on to that now, I guess I'd say. No, it's more like it would cost you $100 a unit and we'll do it for $75, and we're actually are saving you money. So.
Next question. Okay. Talk right into the mic or I'll chastise you.
I will try to follow instructions well. Thank you all for your perspectives today. My name is Christopher Lemon and I serve as Vice President of Community Investment for the Ann Arbor Area Community Foundation. I have two questions. One is kind of an obvious one, and that is, where would you say are the spaces in which philanthropy can support such initiatives? Recognizing that some funders believe in more of like a one-time influx of funding. Some are built for a longer term, kind of a sustainable funding model. But where would you see are some of the more beneficial places where philanthropy can support? And the second question has to do more where there has already been reimbursement in place. I'm curious what the lag time is between the service being offered and then the time for reimbursement to the CBO doing that.
I'll
Thank
answer
you.
it first. I'll answer it first. I would say philanthropically, infrastructure, data infrastructure, systems, and it's expensive. Again, I don't know. The CBOs know how to operate in their space, in the network. They should know what to deliver a meal. They should know to help people get their social determinants figured out, how to build a centered plan. But what they don't know how to do is cross communicate with each other, and because they have been living in a stovepiped world a little bit, and now the person comes with a problem that hits 4 different stovepipes, and the plan wants you to solve it as a hub. And so the hub has to, kind of just like the wheel and spoke, has to make sure that the information is being referred to a variety of, if the person comes with food insecurity, housing, and transportation, you might be talking 3 CBOs that are dealing with this, 3 service deliveries that are occurring. So that technology that's out there, correct me wrong if I'm wrong, Nikki, when you got that data system and so on and so forth, that was a huge game changer for you. It allows you to work with that plan and get them and have your network work with that. We don't have that. We're doing here in Maine, we're doing it off a secure SharePoint site with our network. And every payer wants us to send something different. And so that's a real inefficient way of doing it. Back to payments can happen very quickly. If we're getting paid, we're paying the CBO. One of the keys, I don't know if the other 2 hubs would agree with me, is finding out not 100% of the payment can go to service deliverer, because the hub has to sustain itself, and figuring out what that sweet spot is, it can be tricky. And so that I'll leave it at that.
I would just add, picking up where you left off, that the payment can be quick, but it is not always, often insufficient, because they're not thinking about, we've paid for these services. Let me back up. We haven't paid for these services. When I worked in healthcare, one of the first steps was, please have a list of community resources so we know that you're leveraging them to support social determinants of health. Never was there conversation about any funding following that referral to the community resource. The assumption is they exist, they have funding, we'll just send folks there. And then to your point, Jerry, the ability to recognize that it's not just the delivery of service, but all of the things that have to surround that, for that to happen in an equitable and high quality way. That's the systems, the platforms, the data analysis, the contracting, all the stuff that Nikki had so well listed on her slide. And then the last piece around foundations, yeah, any of that upfront money that Nikki has talked about, I titled the slide that talked about us all 3 being in the CLE grant with US Aging. Perfect timing is always, there's always opportunity for that, for us to take those learnings and to do better. But that's not typically embedded in the little bit of funding that we get for transactional services. So anytime there are funders that are willing to invest in how we structure, build infrastructure, expand, standardize, and do quality improvement, that's so necessary.
Yeah, just to add one more thing to the funding piece is, as much as you can make it flexible, and trust the CBO, how they've got to learn how to spend it. We've received grants different ways. Sometimes there's extensive reporting. There's, it can only be used like this much for this much and this much for this. Well, when you're developing a hub, you're building it as you go, and you don't always know what I'm going to need it for, but I'll tell you, it's all going to get spent on the development of the hub. So as flexible as you can be, and yeah, there's a lot of infrastructure funding that's needed, especially on the IT side, because if you think about it from the provider world, they all received 90/10 grants to get their EMRs all interconnected. None of the CBO world had that. So these hubs are trying to do that on behalf of the CBOs to get us connected with the providers to make those referrals easy. And so all these regions, we're just trying to all scrape it together to get us all connected so it can be a functional referral. And we have the capacity to deliver those services. But it really has to be a partnership amongst the provider groups and the CBOs and then the funders for your community to come together and make it a success.
I would just add one thing too, in that, and this might not be a direct answer to the question, but there is this perception out there that healthcare has that the CBOs are just paid to do this, and that they should be able to make a referral. I heard this weekend a gentleman was discharged from a hospital, an amputee who, I guess he's food insecure. And they were like, well, Meals on Wheels, discharge him. Now he'll just get Meals on Wheels. And I couldn't believe it. I'd like in this day and age, I was almost like going back 15 years. And it wasn't in the hub. It wasn't involved in that. They just thought, oh, make a referral. He'll have meals the next day. Well, that's not true. Title III, Older Americans Act, you have to do an assessment. You have to do this. You have to do that. It takes a week or two, or hopefully less than a week, but it could take longer. And then and so if the health plan wants that, if they want meals at discharge, if they want something, I'm using that's a very simple low-hanging fruit, and they want there could be a wait list for Meals on Wheels. If they want that head of the line privilege, they got to pay for it, and that seems to stun them, stuns health plans and stuns health systems. That what I have to pay for that, and the sad thing is my experience. Maybe Nikki and Christy have a little bit better experience. Is the minute they need to feel like they have to pay for it, they just walk away.
We've had some that paid for it, but we also had stunned expressions, and it took quite a while in the steering committee days to get anybody to accept that reality. Like they were like, but you have these services already. And we're like, yes, but our funding is restricted to specific kinds of people. And oftentimes the healthcare entities are trying to get services for people that don't fit into those restricted categories. So they either don't have a specific diagnosis that qualifies them for that, chronic care, or they don't meet the age requirements or homebound requirements when you're talking about Meals on Wheels, Yeah, so absolutely, getting healthcare entities and our partners to understand that the funding that we have in existence is not the same. It's not going to cover your patients. You're adding patients to the capacity need, and so we need funding to make sure that CBOs can rise up to that challenge and meet the capacity.
Yeah, so there's a couple of Q&A questions that were answered in the chat that looks like they were offered or answered in text, but wanted to speak on one of them. One of the questions was around, for hubs just getting started, whether it's easier to start working on providing a service or establishing contracts first, or how do you manage building out services while also trying to create standardized contracts that will work maybe, in the future across multiple different services?
Well, I answered, so I will share what our experience was. When we were just getting started, oops, my camera went weird there. Okay. I don't know what's happening with my camera, but I'll just be blurry for you. Okay. We were, one of our AAAs had a diabetes self-management program happening. We knew it could be billable under Medicare Part B. So we combined it under the umbrella of the hub with the other AAA that also had the same program and became one program. And then we went out, so we developed the program first, got it all accredited, so we knew it could be billable. Then we went to the health plans with a proposal and said the Medicare Advantage plans, because it's already a Medicare Part B. That means that they have to provide Medicare Part B benefits to any Medicare Advantage plan member. So we were giving them a drop-in program that they were going to have to reimburse for anyway. And now they had a local regional network to deliver that diabetes self-management program. And they agreed, and we got 3 contracts through that. But at the same time, when we were in that meeting, we also said, and why don't we also add on the diabetes prevention program that we have, that we are also developing under an umbrella situation, so that you're not just hitting your people that already have diabetes, but also the folks that have pre-diabetes. We kind of packaged it as a program. And then we went from there, and we kept talking to the health plan about, well, what are your needs of your members? And we looked at their HEDIS metrics. We saw, oh, looks like you only have a 3 on your HEDIS scores, which 5 is the highest. And for those who aren't health plans in the room, if they're at a 3, that means they're losing money on what they can bring in from CMS. So we shared, we have a falls prevention program all set up. Our folks are delivering it, and we could provide it for your Medicare Advantage members. So they wrote that into our contract, and similar programs we added after that. Just talking with them. Sometimes they'll come to us and say, hey, here's where our members need help. How can we partner? And we'll co-develop and strategize a program around it. So I'll pass it off. Sorry, got a little long-winded there. Let me try to fix my lighting.
Yeah, it's another chicken and egg thing. I think, we have to have a critical mass of CBO services to be meaningful with a network. But then, Nikki, I love the way that you put that, really working side by side in partnership to determine what a specific contract looks like. And I can give you an example. We recently were having a conversation with a commercial health plan who is very intrigued by medically tailored meals. And knowing that we have been delivering meals to some of their members, we could talk about the fact that it's hard to catch some of your folks at home. Medically tailored meal doesn't have to be a prepared meal. It can be the ingredients for them to prepare the meal. And so we may be piloting something like that. It's a little variation on home delivered meals.
I'd like to add something. And what Chrissy just said made me, and it might not be related to the question, but it made me think of something. CBOs have to be, and I'd love to hear Christy and Nikki's response to this, have to be ready to change too. One of the things that we struggled in on that, are struggling in on that work, is say a AAA. Well, I deliver home delivered meals, but Christy just said something. The hub can deliver ingredients. They don't have to deliver the meal like it did under. We don't do that. Well, what do you mean you don't do that? You can do that. But being willing to do it differently because it's not Title III or Older Americans Act or something else, that we can create a new service, and that's something that plans shouldn't. So maybe it's the question that the person was asking before. Plans should not be think they have to fit things into our bucket. We can work through and figure out a new bucket together. But CBOs have to be open to change too. And I don't know if there's CBOs in the audience, but if you want to be in a community care hub network, you can't just do it your way as well. And so that's something I like that. I like that idea of delivering ingredients.
Yeah, they have a term for it now. It's called medically tailored groceries.
Yeah, I know.
Yeah,
I would agree with. I'm sorry, Teen. Did you want to go?
I was
just going to agree with. Okay, I was just going to agree with Jerry. It took us a while to get all of our AAAs in our region. we started with the two that were at the table. We always start with, okay, who's at the table and wants to proceed? But I think what's helped us is by having the CBOs in the committees and hearing the opportunities coming out and explaining how that it would make a difference for their organization so they can ask all their questions and not be kind of caught like just asked to join, but they're actually helping inform the work. It was really helpful, but it did take a while, the first couple of years, to get all the AAAs, but now they're all participating, they're all contracting, all receiving funds from us for the delivery of different services. Yep.
Yeah, I was just gonna add that nimbleness is essential on all of our parts. And we've had a lot of experience with kind of just experimenting and thinking about different ways to approach deals. But if you even start with that whole, premise of AAAs, start thinking beyond that, basically we did a review of our landscape and saw different CBOs in the region that were providing services that weren't specific to Older Americans Act services, but were nimble enough to be able to offer these services to plans that cover the full range of age. So we partnered with Early Learning and Head Start, for instance. We partnered with YMCA and other community-based organizations that are providing education and health promotion services already. Bringing these newer partners into the fold also helped us to broaden our thinking and kind of shake things up. The other piece that we were able to do with our health entity partners was that they started coming up with a new way of funding some of those services that are a little bit more nimble, and we call it supplemental expenditures. And so one of our healthcare plan entities, for instance, provides a pocket of money, $200, to assist a member with something that we aren't normally thinking of. So we can go on Amazon and send them a microwave if they need that in order to cook their meals that we can deliver to them. We can pay a rent. We can pay, they've come up with different ways to be really helpful to their members that aren't in those buckets like you talked about, Jerry. So being nimble to do that is really, really helpful too.
All right, I think we have time for one, maybe two questions if we are quick about it. Had one over here.
As long as there's time. So I have a friend in the room. I'm also with a health plan and with McLaren Health Plan, knowing that we operate over the entire state of Michigan. One of the things that comes to mind is community reinvestment, and that health plans have a role in that in the coming years. And I'm just curious, based on your guys' experience, where that should be used. What should we look for in CBOs? Where are the major checklists that need to be checked off to be able to reinvest in the community, to be able to make this program sustainable versus the short term?
Yeah. I was at a Medicare conference, Medicare Advantage conference sometime almost a year ago, but not quite. And I had a conversation with Point 32 Health, which is Tufts and Harvard Pilgrim getting together. And they were highlighting all their community reinvestment, and they built a vegetable garden here, and they did this here, and they did that there. And I said, that's good stuff, but that's not. You have to make a decision, I think, in your community reinvestment. Are you going to check a box, or are you going to do game-changing investment? And or a little bit of both. But when you're doing game-changing investment, and I don't know if it was Nikki or Christy who said it, the ROI is a little bit further down the road, and you don't get the photo op. Because the photo op there's no vegetable. You can't necessarily put an IT system in a brochure, but you could put a vegetable garden or a new playground in a brochure. So that's something that you have to. And one of the things, I sit on a national committee called the Partnership to Align Social Care that's working on community care hubs and so on and so forth. And there's a lot of plans at that meeting big plans, national plans. What I worry about or get concerned about is the C-suite is not there. The suite seat is disengaged from what, what I am envious, if you haven't figured out, of Nikki, in that she has this local regional plan, that she has a personal relationship, and she's talking to the executives of that plan. And that's so neat. And so if any of you guys in the room are local plans, the hub, who's ever looking to form a hub, latch onto them, because you build that personal relationship, you can really make significant change. Because the C-suite at Avalanche and at Aetna are so far removed, and they're working towards some other goals that maybe are not related. And so that so when you're doing community reinvestment as part of your plan requirement, think about, well, I think I got the attention of point 32 health, and I hope we are going to have a good conversation in January. But it took me a year to almost get to that, to where we're just having a conversation.
I think we're going to try to get one more question in. Anybody else from the audience or on the Zoom have a question for the panelist? Coming right to you, Josh.
So first, I'd like to thank the panelists today. So Josh Traylor, Executive Director here at the Center for Health Research and Transformation. There was one slide that I think really encapsulated the issue well, which is you have payers who say, well, I'm worried, or healthcare partners who say, I'm worried that there's a capacity to deliver services. And then you've got CBOs who say, we need the funding in order to be able to deliver that capacity. And so, I think as you're trying to build out that capacity, you have this tricky job of, we have to make investments in workforce, we have to make investments in data infrastructure, we have to figure out the payment models, we have to keep enough CBOs involved to have a meaningful network. We also have to keep the payers and the health systems committed enough so that those CBOs have confidence that if they build it, they in fact will come. And so I'm curious, all of you are in different phases of your transition as a care hub. Any tips, tricks, advice for us on how to manage that coalition, keeping the CBOs at the table, keeping the plans and the health systems at the table, while also identifying seed funding, be that federal grants, state grants, or private philanthropy?
So having been on the medical side, I would say, and one of the most important things you can do is shift your own thinking and not think about the community support, again, where 80% of health outcomes are influenced, as a nice to have. That's where we've come from. And it's really, really hard, I can say, being on the clinical side, to think outside the walls of medicine in terms of what impacts outcomes. But you've got to really challenge your thinking to fundamentally shift not only how we invest, but how we think about communities' influence on health outcomes and the health of our communities. And so I think you got to start there. You got to challenge yourself and the people around you to just completely think differently. Until we get to that sustainable point, I mentioned that my greatest fear is that the richness in the community, you saw my language about meeting folks where they are, it's where they have trusted resources. If that goes away, the amount of time and effort it would take to rebuild the infrastructure we have today would take generations. And so if we don't figure this out quickly and shore it up, I think it's going to be really challenging to ever meet those healthcare outcomes, especially as two-sided risk becomes more prevalent.
I agree 100%. And I would just add, oh, sorry, Kate, go ahead, Nikki.
Just a couple just practical ways to keep everybody engaged. First of all, just to get started, you can start with pilots. Start with the folks in the room at the CBOs who are champions and want to get started with a pilot and the health plan that's ready to go to start a pilot with one program, prove the model, work out your infrastructure systems, and go from there. Once you really get established, it can move pretty quickly and you can add on more partners as you go. So you're not spending a lot of time constantly trying to recruit more partners, but you're going with the ones you have to prove the model with the pilot. And the other thing is for the CBOs that maybe aren't ready to contract today, but they're interested, just constantly keep them engaged, but not add administrative burden to their life. They don't have a lot of funding as it is. So anything that we ever develop, we're always thinking, is this really something we need from them? Is this a process that we need to add to their lives in order for them to do this service? So really making the workflows and any kind of infrastructure, any kind of opportunity for them to engage as easy as possible. Go to them, don't make them come to you type thing. There's just a couple tips that I would recommend.
And I would add that to Christie's point, especially, I'm going to show my age. What made Michael Jordan or Wayne Gretzky great was that they always positioned themselves where the ball or the puck was going to be 3 moves later. And so I think a plan and CBOs too, healthcare and CBOs, this is where it's going. This is where the cost of critical care does not solve. This is where it's going. This is how you make people stay in the community, live fruitful lives, addressing their social determinants, addressing their health-related social needs. And yes, you might not be getting penalized right now, and no, you might not be getting the reimbursement you're originally hoping for as a CBO. But if you play the game, if you get into the game, you will be there when it starts becoming useful to your overall agencies or health plans, goals, and objectives. And so get to the where the puck is going to be in 5 to 10 years. Don't look for just today return on investment.
Thank you so much. We are right at 5. We want to be respectful of everybody's time. So thank you to, standing right in front of the camera for you guys. Thank you to all of our panelists. It was excellent conversation and presentation. I'm gonna give them a round of applause, please. And again,